Married lady who was coming from Chandannagar, West Bengal. She had a long history of holocranial headache since early childhood, around 12 years of age, whose character initially was throbbing in nature, and it used to persist for about half a day, and she used to get relief with topical analgesics applied over forehead and by taking rest. With menarche, at 14 years of age, the headache intensified. It retained its throbbing character. It was accompanied with vomiting. There was presence of phonophobia, and this time she sought some medical advice and was given symptomatic treatment with vasopressin. She used to get good relief with that medicine, and she kept taking frequent doses, and her attack frequency was 1 to 2 attacks per week. During her college life, she suffered from some menstrual irregularities with heavy bleeds, for which she visited a gynecologist. She was prescribed OCPs for her polycystic ovaries, and this worsened her headache. She used to take multiple vasopressin tablets, ranging from 4 to 5 tablets per day, to get relief. And she reports headache frequency as almost daily. She ultimately got married in 2020 but failed to conceive for 2 years, for which she took some ovulation inducer drugs which caused severe adverse effects, and she discontinued that. Since March 2025, the story changed. This headache had developed some new features. There was an intense right-sided earache which was sharp in nature and was unaccompanied by any oral discharge or any hearing loss or tinnitus. She consulted some local ENT physicians, but she didn't get any prompt relief with the prescribed NSAIDs or antihistamines. Later on, she was prescribed by some ENT physician a brief course of steroid, which seemed to provide her with great relief. But it was a short-lasting relief. A month later, she developed severe electric shock-like sensation over the right side of her face, around the temporal region, forehead, and right cheek. She also noticed difficulty in chewing food with her right jaw. It was intermittent in nature, the neuralgiform headache that is being told. It was intermittent in nature initially, but subsequently it was present throughout the day, and it used to interrupt her sleep. The pain was unrelated to any change of posture or straining. Within a few days, she developed a change in her voice and a persistent cough throughout the day, making it difficult for her to swallow her food. And her husband of late noted that there is a slight bulge over the anterior and lower part of her neck. She obtained no relief with the over-the-counter cough syrups, and for the last 7 days before presenting to us, she had started developing a high-grade fever with loss of appetite and generalized weakness. Among the important negative history that we took, that there was no history of any visual disturbance, auditory disturbance, any change of smell, any facial deviation, any nasal intonation or regurgitation. There is no reported history of any limb weakness, neither any sensory symptoms nor any balance problems. Our sphincter functions were reportedly normal, and there was no history suggestive of any joint pain, rash, or oral ulcers. So up to this is the history part. If you can discuss something.
Summarize the history just.
This is a 31-year-old female who had a long-standing history of holocranial throbbing headache from her school life, which was initially relieved by taking vasopressin. After her menarche, the headache intensified, On taking OCP, the headache became worse. For the last 3 years after marriage, she had some conceptual difficulties. And of late, since last March, she has developed some new symptoms like a right-sided hemifacial neuralgiform headache, right earache, difficulty in chewing with the right side of jaw, and some hoarseness of voice. And just before presenting to us for a week, she has been developing high-grade fever.
So what we have is essentially a person whose headache history of very long duration. She's been having headaches even before her menarche, and post menarche the nature of the headache was somewhat resembling that of a migraine, and he had relief from migraine relieving medications. And then she had PCOD, and she had sensitivity to estrogen. She had irregular cycles, whereas because of the PCOD, and the headache became more when she was given estrogen, suggesting that she had some characters of menstrual migraine or estrogen sensitive migraine. So up till that part, it is clear to me what was happening. But then she developed this right-sided facial pain and this problem in swallowing on the right side, this sharp pain and the hoarseness of voice and other things, and it began with some systemic features about 7 days prior to admission. So it is difficult to correlate the whole history with what has happened now until I have more information. All what I can say is that there was some predisposing condition, and on top of which there has been some systemic inflammatory cause causing this kind of thing, which may be elucidated further on whatever comes up from the investigation. That is what I can think just from the history at this stage.
Right. We also thought in the same line. The initial part was looking like a primary headache, but there are some new developments that has changed the profile to a secondary headache.
Definitely, patient was suffering from migraine headache initially. Add on that, there is a red flag signs. Number one is fever. Number two is the hoarseness of voice. Definitely, it is a inflammatory, infective or non-infective. These are suggestive. Maybe in this case, sarcoidosis we have to think. Sarcoidosis, it may present with the red flag sign number one, migrainous headache, along with, if it is non-infective, that may be sarcoidosis or other, like lymphoma or other thing. Because of that, the structural lesion, yes or no, that to be looked at.
So, anybody from the audience, Dr. Chaudhary, if you have anything to say at this stage? Yeah, I have no idea.
Spot on. Yeah. Spot on. I can even give the examination.
Yes. So we considered the anatomy as the trigeminal-vascular pathway for the initial part. Later on, the neuralgiform part seems to be affection of the trigeminal nerve, hoarseness due to the recurrent laryngeal nerve. The pathology seems to be a mixture of both primary and secondary, inflammatory or neoplastic. So the general examination of this patient was, she was the average build and nutritional status. There was no pallor, icterus, clubbing, edema or engorged neck vein. There was a presence of firm swelling over the anterior aspect of neck, overlying the trachea, filling the suprasternal notch. It was non-mobile with swallowing. There were a few tender spots. There was no overlying skin changes. Lower part of the swelling cannot be traced through insinuation of finger through the suprasternal notch. Chest examination revealed normal vesicular breath sounds. Abdominal examination revealed no organomegaly or any tenderness or any dullness on percussion. In the neurological examination, olfaction was normal, visual acuity, field of vision, fundus, even the slit lamp was done, it was normal. Extraocular movement were full, pupils were normally reacting to light and accommodating. There was a right-sided jaw deviation on opening her mouth. There was weakness of the right temporalis and masseter. There was paresthesia over the right V1, V2, V3 distribution. And there was absent direct and consensual corneal reflex when stimulated on the right cornea. Jaw jerk was not elicited. There was no facial asymmetry on clenching her teeth. Auditory examination was normal. Palatal movement, gag reflex was normal. Voice was hoarse. Tongue movements were normal. Meningeal signs were absent. Motor examination was non-revealing. Sensory examination was also normal. Cerebellum gait testing were normal. Here are a few examination findings. Clenching of teeth reveals no facial asymmetry. But on opening her mouth, there is a jaw deviation which is small illustrated in this part. And this is the picture of the swelling over the anterior part of the neck. This is the corneal reflex on the left. On the right, there is no direct or consensual reflex. And on vocal cord examination, there is an immobile vocal cord on the left side. That attributes the hoarseness. This is the ENT findings. There is a mild conducting hearing loss in the left ear. In the blood works, almost everything was within normals except for the SGPT, which was a bit high, the GGT, which was a bit high, LDH was markedly raised, CRP was also high. The rest of the examination were within normal limits. This is the CT of the patient. There was nothing very conspicuous on the CT, to be frank. So, considering the neurodeficits, we had to go for the MRI. I will be dealing with the MRI a bit later. Meanwhile, the USG of neck was conducted. It showed ill-defined hypoechoic heterogeneous mass extending from superior mediastinum into the lower part of neck. It measured 46 into 26 millimeter with internal vascularity noted in some areas. The tracheoesophageal groove was obliterated by the mass. Thyroid gland, right lobe, 8 into 7 millimeter. Isthmus 10 into 6, left 6 into 5. Nothing very characteristic. There were a few cervical necrotic lymph nodes. This is the MRI picture. The contrast MRI was carried out. The only finding that was noted was in this part, the paracellular part, that showed an enhancing lesion on the right side. That was the only finding that was present in the MRI. There was no other meningeal enhancement or any other parenchymal lesion observed anywhere in the MRI. So this was reported as an enhancing plaque. The report mentioned the provisional diagnosis of a meningioma. That was the diagnosis given by the radiologist. But we are not satisfied with that diagnosis because the patient had many lesions which could not be explained by this right-sided lesion, particularly the left-sided vocal cord pulse. That cannot.
Hold on for one. Should we get surprised by the fact that the MRI does not have any parenchymal lesion in this particular case? Clinically speaking, probably not. This would be a because of the fact that initially the character of the headache was primary to start with, involving the pain sensitive areas of the brain, and later on, now she has got involvement of her cranial nerves, 5th cranial nerves, 10th cranial nerves, like that. And she probably does not have any clinical features of involvement of intraaxial system. She does not have any internuclear ophthalmoplegia. She probably does not have any long tract signs to start with. So initially, to start with, it was involving non-specific pain sensitive areas, and later on, cranial nerves were involved. Without clinical features of involvement of long tract signs, internuclear ophthalmoplegia, pupillary asymmetry, and things like that. So it was originally on the basis of clinical findings and extraaxial something. It could be in the meningeal process. Meningeal process was there involved, although frank meningeal signs were lacking. So here we are at this point of time. So in this particular case, the clinical finding and MRI up to now, they are not completely discordant. Now please go ahead.
to track that mediastinal extending lesion which was pointed in that USG neck, we did a CT thorax and abdomen, which showed this huge mediastinal mass that is present. It is pushing the cardiac shadow below towards the diaphragm. That is a huge mediastinal mass. Also, the abdomen showed multiple loculated liver shadows. So it was reported like that it can be possibly a thymoma oblique lymphoma. But considering that clinical profile, that meningeal thing plus this mediastinal mass, we are pretty sure that we are not dealing with thymoma. So we have a hunch that this patient might be having some sort of lymphoproliferative disorder. With this idea, we carried out the contrast enhanced MRI of whole spine. It had only a sacral arachnoid cyst which are compressing few sacral roots. The true cut biopsy was taken from that neck swelling. So it came out that it is suggestive of a lymphoproliferative disorder. Next, a PET scan was done, which revealed avid spots almost throughout the body. We are very surprised with this finding because the patient did not have so much of clinical findings, but this PET scan showed almost everywhere there were avid spots. This mediastinal part is there, liver part is there, this paracellular part that was there on the CT that is also showing uptake. And as you can see, almost in every line there is FDG avid lesions everywhere. Middle cranial fossa, cervical levels, anterior mediastinum, lung, pericardial deposits, breast, liver, gastric wall, pancreatic body. Almost every part had avid uptaking spots. Meanwhile, immunohistochemistry was also ordered, and that came out as consistent with diffuse large B cell lymphoma, non-GCB type. So this idea of presenting this case is that we are familiar with lymphoma as a clinical entity, but CNS lymphoma practically we see very few cases. And also in such a young immunocompetent patient, that lymphoma presenting with a transformed primary headache with so many cranial nerve palsy and such extensive disease is very uncommon to us. The workup we did took some time, but we could finally reach a diagnosis. And we reviewed the literature as to what is the CNS lymphoma as a disease. And we took some points from this patient. It is lymphoma can arise in the CNS primarily, that is known as primary CNS lymphoma, or the CNS can be involved secondarily. It may be a systemic lymphoma which is secondarily involving the CNS. In this case, it is the secondary CNS lymphoma. There is systemic involvement, CNS was a secondary spot. Almost any lymphoma subtype can affect the CNS. The most prevalent form is the diffuse large B-cell lymphoma. The difference between primary CNS lymphoma and the secondary CNS lymphoma is primary CNS lymphoma is usually parenchymal involvement. Secondary CNS lymphoma is usually meningeal involvement. And not only the meninges, it can also extend to involve the spinal cord and the vitreoretinal space. So the spinal cord imaging is essential even if the patient is not symptomatic for that. And an ocular examination is also essential. The reason for knowing this neurologic involvement is important in the management decision because most of the therapy that is given in the systemic lymphoma does not cross the blood-brain barrier. So the therapy has to be individualized. You have to select some agents that has got good penetration into the blood-brain barrier. It is a rare group of disease, accounting for 2% of brain tumor, and it is usually a disease of elderly, with the peak incidence at 75 to 84 years of age. Risk factors are immunosuppression, post-organ transplant, where the Epstein-Barr virus is the main culprit. Secondary CNS involvement can occur in treatment naive or as a relapse. Prognosis is bad if CNS International Prognostic Index is high. This score is composed of these points: age more than 60, high LDH, poor performance status, stage 3-4 disease, more than one extranodal site of involvement, renal or adrenal involvement. Secondary CNS lymphoma is a rare complication, 5% of systemic disease. CNS involvement of systemic lymphoma is thought to occur via several mechanisms like hematologic spread, direct extension from adjacent bone marrow, centripetal growth across neurovascular bundles. Other indolent B cell subtypes are reported, but most common is DLBCL. T cell lymphoma has also been reported, but the most common is the diffuse large B cell. Leptomeninges can be involved more than parenchymal disease in secondary CNS lymphoma. The treatment comprises of two arms. One is the induction and one is the consolidation, because these are known to relapse. Even if you have a good response to the induction therapy, they are known to relapse, and almost always they relapse until and unless you put them on consolidation therapy. The induction is given by high dose methotrexate regimen from 5 gram per meter square to 8 gram per meter square. Without this, the conventional R-CHOP may not be sufficient, because this methotrexate is the drug that has the potential to cross the blood-brain barrier in very high doses. The consolidation is aimed by myeloablative therapy followed by autologous stem cell transplant. Other possible therapies can be non-myeloablative chemotherapy or whole brain radiation therapy. There are some novel therapies like BTK inhibitors, immunomodulators, CAR T cell therapy. And follow-up is extremely essential. Even if the patient has a cure and relapse-free rate, the follow-up is essential, because patients have been reported to relapse even after 10 years of remission. So follow-up is very, very essential. It is a very unfortunate story of this young lady, that she has such a devastating disease which has extended throughout the body. And initially unsuspecting primary headache suddenly changed character after her marriage. So this is a very sad story of that lady. The lady is currently undergoing treatment at an oncologic institute. She had been put on R-CHOP itself. They have not added methotrexate, but maybe we can talk with the oncologist to suggest that. Thank you.
It was indeed a very different kind of a case which we neurologists commonly do not see and commonly do not think of. Before you showed the PET scan and other stuff, I was thinking about the anti-diastolic mass, I was thinking of a thymoma. At one point I was thinking whether it could be IgG4 related disease. But here you've got tissue proof and you've got the PET scan, and so the diagnosis is established that it is diffuse B-cell lymphoma. The outcome of this case will not be good in our probability, although we have limited knowledge over it. But thank you for presenting a very different kind of a case from the normal things which we have in a headache. Thank you.
And I sincerely thank my teacher, Dr. Gautam. He has been the main lead in referring this case to us.
Very good.
See, the point is that the patient had a primary headache, right? And then later on she developed a neuralgia, facial neuralgia, if you could broaden the term in that context. And then she started showing up red flags, swelling, and other things. So the point that is important to understand is this, that one, the patient with the primary headaches are not immune to a secondary pathology. So they can always have a cause to cause the, either to exacerbate. In this case, it was a different phenotype, but even the migraine can get exacerbated or get worse by a secondary pathology, which might develop over time. So once diagnosed as migraine does not mean that lifelong that migraine attack will continue. You have to be vigilant. So that is a learning point, I think, one from one this thing. And secondly, even the headache types might change. So we have seen patients with a migraine phenotype later on, presenting like a TAX, presenting like a trigeminal autonomic cephalgia, and then you find a Tolosa Hunt or a cavernous sinus pathology lurking there. So one has to be careful so a patient can have a multiple headache diagnosis. The headache diagnosis may change over a period of time, and a primary coexisting headache may be associated with a secondary. So these are the important learning points.
When this lady came to me, that is the history. During that time examination, there is a flip-nap palsy right-sided, both motor and sensory, and there is a swelling in the neck, lower part of the neck. And she came from a poor middle-class family. She initially divorced, and during this illness, I again rebonding with her ex-husband. Everything was ready, but after the admission to the I called Dhiman, he admitted her and reviewed the case because it is not possible for this lady to evaluate in the outside the government sector because of excessive cost. I thanks to the Dhiman and total team there because they evaluated very clearly and very thoroughly, and that is the party is the patient party is very much they are satisfied with the treatment protocol, everything. But naturally, she's not receiving
He has
chemotherapy.
responded to the induction therapy. He
Induction.
has got three courses of chemotherapy right now.
Psychologically,
But she's on a constant follow-up.
yeah, psychologically depressed. Naturally, from the initial there is the family disturbances, and now again rebonding, but there will be this disease.
For sharing this excellent case. And now I would like to invite Professor Kumar Banerjee sir to felicitate speaker and panelists.
Sorry. Next, I would like to invite Dr.